Hey there, Kelly.
Hey Joe,
How
how's
are
it
you
going?
doing?
I'm good.
Good, good. Let me pull this up.
Yeah, go for it.
Hey everyone, thank you for joining today. We're going to get started probably a couple minutes after the hour. Yeah, we'll get started soon. All right, I'm going to go ahead and get started for us today. I am really excited to be talking to everyone. It's actually my last Lunch and Learn series, and so I'll have a little note about who's going to be taking over after me today. But, it's for such a solemn and sad topic too to talk about overdose, especially the sort of impact of COVID-19 on the current opioid overdose crisis around the United States. And so I wanted to review a little bit about sort of the current state of the nation currently around opioid overdose, and then really give a functional guide on how to actually reverse an overdose. So we're going to be going through the actual application of Narcan or naloxone after we sort of give a brief overview of sort of what's happening currently in the United States. So I'm hoping today can be like a super functional lunch and learn where we actually learn skills on how to actually reverse overdose. So I'm excited for you all to join today. So, okay, what do we mean when we say overdose, right? I think it's like a common term for, like if I have like a big bag of Doritos, I might say like I overdosed on a bag of Doritos and like junk food, and like we know that that can have some negative health outcomes as well. But when we're really talking about overdose, we're referring it to it as a biological response to when the human body receives too much of a substance or a mix of substances. And I've really broken it down today into two sort of main sections of drugs. One is depressants, and while both depressants and stimulants are obviously affecting the central nervous system, depressants are obviously having a depressive effect on the central nervous system, anywhere from affecting the respiratory system, also affecting like the GI tract and things like that. We know that opioids can have this effect throughout the body. And so although we're I think, primarily going to be talking about opioids today, this can also include like benzodiazepines, which would be the wide variety of different drugs like Xanax, Valium, things like that, that are going to also depress the central nervous system. And alcohol is an obvious other choice there as well. We also know that when you mix these three drugs specifically, the overdose risk is going to be quite increased. And so we, really talk about those in a group, but it is important to recognize that the antidote naloxone, which we'll be talking about a lot more today, is only effective against opioids when there's an opioid overdose in the system or an influx of opioids flooding the receptors in the body. And so what we see with this type of overdose, though, that's most common in people who are especially dying, is a respiratory failure. And so we'll talk about some of the signs that we can look for when somebody might be experiencing a respiratory failure due to overdose. But at the same time, we also, since we know that stimulants are also affecting the central nervous system, they're essentially having the opposite effect, right? And so it's going to be a increased heart rate. We're going to see like increased blood pressure, hypertension. And this is obviously caused by methamphetamine and capital C, lowercase cocaine, apparently. And those are some of the more popular stimulants that we'll be seeing. But this could also, you might see this with like Adderall and other prescription drugs as well. And instead of sort of respiratory failure that we're seeing with a lot of depressant overdoses, what we see actually more so, instead of even calling it a overdose, we actually see a overamping of the blood supply. And so what we see most common is our cardiovascular failures, cardiac arrest, heart attack, things that may, all the symptoms that may come along with those ailments as well. And so, for depressants, though, we're looking, interestingly, in later stage of both of these, the symptoms start looking a little bit more similar, especially if you're talking about like confusion or mental capabilities, capacity at that time, if somebody's ingested too many of these substances. But very generally, if we're talking about depressants, we're looking for like slow or irregular breathing, pale or clammy skin. With that, this blue tinge can come, blue or gray, depending on an individual's, the color of their skin. We see also that speech is heavily slowed or slurred to the point where somebody might not be able to communicate. And then there's this sort of phenomena that we call heavy nod, which is essentially as an individual is increasingly getting high from the substance, the ability to actually control the weight of an individual's head is affected as well. And so what we see is sort of a slumping of individuals' body parts as well as they're responding to this overdose. With stimulants, though, again, what we see would be a little bit more similar to a cardiac arrest or some sort of cardiovascular failure situation where we see jerking or rigid limbs. There can be a high fever associated or, unsurprisingly, a rapidly increasing pulse. We also see chest pain, which would be unsurprising, especially the effects on the heart, severe hypertension, and of course, unfortunately, cardiac arrest is something that we would look to. I think that the important thing to really note here is that there is no current FDA approved like overamping overdose response for stimulants. And so often what times emergency departments will do is they'll introduce like an oral charcoal-based sort of suppository that somebody will take to be able to soak up some of the drug, but like other than that, there unfortunately are not a lot of tools that we have currently to reverse like the high ingestion of a stimulant. So, one of the reasons I really wanted to do and cover this topic at least today is that, hopefully if you all have come to some of these past sessions, we'll have covered this graphic. And just really briefly, in the past, we've looked at this sort of current opioid epidemic crisis over the last 2 decades, as we've seen the increase of prescribing, especially in the early 2000s, of individuals really being overprescribed prescription opioids, which you see in the purple line here, where we saw this is reflecting deaths per 100,000 due to opioids, and so we see that pretty sharp spike up in the early 2000s. What we saw though around 2010 was the implementation of like prescription drug monitoring programs, which vastly decreased access to a lot of prescription opioids. So a lot of people started transitioning to other opioids that they could find, which often in that case was heroin. And what we saw though is as this shift was happening and there was a law enforcement and systemic response to also clamping down on heroin access, people who were developing these drugs looked for cheaper alternatives, as is the capitalist way, and it found that if they introduced things like fentanyl and other synthetic opioids, they'd be able to create much larger amounts of drug for people to access. Therefore, we see this huge spike in other synthetic opioids, where people really just may not know what is in their drug supply at the time, right? And so if somebody doesn't know and they're not taking potential precautions to test their drugs and things like that, which is also heavily stigmatized, and that access to those types of tools are heavily restricted, that we see a lot of people who are overdosing who, again, are just not knowing the content of their drug. Some of what I'm hoping to talk about today, though, is what we've seen, and I really appreciate Patrick for actually alerting me to this article as well, but what we've seen currently, especially during this pandemic, is what some researchers are estimating to be about an 18% increase in opioid overdoses around the country. This is following a 5% increase back in 2019, where we had over 72,000 people die from an opioid-related overdose or other drug-related overdose, the majority of those being opioids, though. And so what's particularly concerning, though, is like, what is the sort of scenario that we're working with now currently in COVID? And you can imagine that, COVID-19 would obviously have a lot of high impact on drug supply, especially between communities and along our sort of regular drug supply routes, as people are more physically distancing and having to sort of reckon with the fact that we have sort of a national shutdown on our borders and that kind of thing, that the types of drugs that people are going to be getting may be particularly dangerous due to the introduction of fentanyl and things like that. And so I think it's especially pertinent that we really review some of the basics around responding to a overdose, because I think if we're looking at current projections for where we're going to be, how we're going to be handling COVID over the next year, it's not going to get any better. And so I think a lot of people in this field are concerned that this is just going to get worse as we continue on through this COVID pandemic. I wanted to show, this is from the Overdose Detection Mapping Application Project based out of DC, and they were looking at the percent change in predicted 12-month count of drug overdose deaths by jurisdiction. And I really appreciate this. I think, especially as we talk about overdose in Nebraska, right? Nebraska is often, we don't have these stark increases in overdose currently. There's some question whether that's sort of buffed by people's preference for methamphetamine or access to methamphetamine in the state. I think that's an ongoing conversation, but I think it is interesting, especially looking at some of the surrounding states that are touching Nebraska as well. We're seeing with these increases. I would say, though, although Nebraska is showing a decline in reported overdoses, it's pretty small, right? So in January 2019, there was 147 opioid overdose-related deaths. In January 2020, this year, there's about 144. Currently, we don't have those data available to understand what is the actual impact currently from COVID in Nebraska on overdose numbers. And I think that'll be really interesting to see over the next year or so, to see how Nebraska specifically has been impacted by that. So I'm going to jump into opioids more, and we can obviously talk about stimulants during the discussion section today, but just super briefly, what are opioids? I think if we're touching a lot of this work, we have a general idea, right? But opioids really are just any drug which is acting on opioid receptors. And we know that opioid receptors are found throughout the body, especially as they might impact the central nervous system. We're going to, again, find it anywhere from the gastrointestinal tract to a respiratory system. We often know opioids, though, as pain medications with that high chemical dependency risk. That we have that sort of fear. That's why we have our prescription drug monitoring programs to prevent what we find, or as other people define as like drug-seeking patients and things like that, from getting access to these medications. But we can see examples of this from heroin and morphine, hydrocodone, oxycodone, fentanyl, Percocet, and Dilaudid. There's many other names out there for opioids. And there's also some drugs, legal or illegal, that actually interact with opioid receptors as well. I'm thinking of like Kava or Kratom, which are legal in a lot of states as well. And so interestingly, some people find those as ways to sort of get off of opioids if they're seeking to do that. But when we're talking about like the actual physiology of an opioid overdose, right? What it really is doing is when we're ingesting an opioids, if we have too much, it's going to be an overloading of those opioid receptors in our body. And, this is causing euphoria, respiratory depression, and sedation to whatever sort of specified degree that the patient is seeking. As we mentioned, though, because it can be easy to not either know what is in your supply, or if you're mixing drugs for whatever reason, that the sort of likely cause of mortality is going to be that respiratory compromise. And so we see this in sort of 5 steps, pretty stark. An individual's breathing is going to be slowing, breathing stops, and what we actually call a death rattle. And that's when an individual is really taking those final forceful breaths that are, the individual is maybe slumped over, their respiratory system is just struggling to actually bring in oxygen. And so eventually that will go to the actual ceasing of breathing. This cuts off oxygen to the brain, and we see from individuals who may be in that state and then reversed later that they could have sort of long-term impacts from that lack of oxygen. But eventually heart stop, and individual may die. But sorry for this sort of blurry picture here, but one of the big things here, I always just sort of think of, I'm not I don't work in medicine, and so I will never pretend to work in medicine, but I think it's important just to sort of think about these opioids are being introduced to the body as a sort of lock and key, that when the actual opioid molecules are interacting with these natural opioid receptors, it can flood the system. But when we talk about naloxone, which we're going to go through in the rest of the portion of this presentation, that's really what the naloxone is really doing, is replacing the opioids for a short amount of time off of those receptors. And so they can still essentially function to continue the life of the body. And so what's really important to note, though, is that this naloxone has a pretty short half-life, up to anywhere from like 30 to 45 minutes. And so as we'll talk about later, it may be necessary to continue administering naloxone because eventually, depending on how the opioids were ingested, the lock and key effect of the naloxone may wear off and the opioids may again overwhelm the system. So really important to remember that. So I'm going to go over some risk factors for an individual who may be at risk of overdosing. One of the biggest ones that we see are people who are using alone. And, it's really hard to sort of understate this, because I think, again, due to the stigma and views that people have on people who are using opioids, either for self-medication, for whatever other reason, it's really easy to use alone because of that shame, or people just prefer to be enjoying that high on by themselves. I think one of the common harm reduction interventions we can have for this, though, is that, at least, tell a buddy that you might be using, leave the door unlocked. If somebody is going to be in a position to check on you, try to find someone who's safe to be around to use. Unfortunately, I think in this world that we're living in, that can be really hard for a lot of individuals too. For people who might be newer to using opioids and not knowing, potentially even their supply, or what is specifically going to be in the drug that they're ingesting. We can also encourage, people to use like tester shots, maybe use half of what you were going to use and see how that affects you and then go for it. Another big piece of this is like tolerance changes that come from an individual who might have just gotten into treatment for a while or have been imprisoned in our incarceration system, which generally is not providing necessary medication-assisted treatment to help people manage withdrawal and things like that. And so an individual getting out, trying to use the same amount that they were using before potentially, and without that sort of tolerance they might have in their system, that could put an individual at pretty high risk for an overdose situation. Mentioned sort of that, again, that unknown content and strength. This is particularly important in the context that we're living in with unknown supplies, things being cut with fentanyl. Mentioned earlier, mixing depressant drugs, alcohol, benzos, and opioids. We've actually been seeing is an increase in benzos specifically that are showing up in overdose or opioid related mortality. And, just I think going in to that narrative of individuals potentially, having a different relationship with all types of different drugs that may unfortunately contribute to higher risk for overdose. Some people are going to be changing the way that they're ingesting the drug. So they may have been snorting heroin. They may have been smoking heroin as well. But for whatever reason, they're changing to injection. That can have obviously a lot more risk when you're injecting straight into your bloodstream, a large amount and concentrated amount of drug versus smoking it, which is going to be a little bit less risky. And then overall physical health, if I am dehydrated, if I'm not eating like regular meals and things like that, impacted by all of the sort of social determinants of health, including poverty and things like that may impact, my general sort of well-being, that can also have an impact on an overdose potential as well. I always like to point this out though, because there is like a different, how can you tell if somebody, you're walking on the street and you may see somebody who is potentially overdosing, you have a friend, whoever, there is a difference between being high and overdosing, right? And, when you're high, I generally sort of describe that your muscles are relaxed. You're obviously getting the effects of these opioids. Your speech may be slowed or slurred. You may be a little bit droopy, sleepy looking. What's really important though is that an individual is still responding to stimulation, like yelling, what we call a sternum rub, which I won't try to show you fully, but is if you just, if a person is overdosing, and we'll talk about this in a little bit, but if in order to get some sort of response, is the person who is in full overdose will not respond to physical stimuli. And so one of the big things is to actually rub your knuckles on an individual's sternum, because it's one of the more sensitive parts of the body, to see if they respond. Another big thing, I don't encourage like pinching or hurting anybody to try to wake them up, but I think a big thing is using Narcan or naloxone as a verb and saying to an individual, I'm a little bit worried about you. I might have to Narcan you if you're not going to be showing a response. If somebody is like with it and they do not want their high disturbed, like they will stop you in that. And if they are able to stop you from administering Narcan, then they are in a state where they're not currently dangerously overdosing. I think it's really important to note though, that can obviously change depending on how much they've ingested or what their sort of current state of being is. Another thing that is really common is actually nodding out, but it is really hard sometimes to determine if somebody's just nodding out or if they're going in and out of consciousness and that kind of thing too. So I think being with somebody to observe those symptoms and experiences is really essential. What we're looking for in an overdose though, as I mentioned earlier, is this death rattle or like a really deep snoring or wheezing. That shows us that an individual is having a really, really hard time breathing essentially and bringing in oxygen to their body because of, again, this effect on the central nervous system that may impact how they are intaking oxygen. We might see from somebody who is deprived of oxygen, that again, depending on their skin color, is sort of a blue or grayish skin tinge. And you can usually look to the lips or fingertips first to really see if that's happening in an individual. We're also looking for pale and clammy skin overall. I didn't put this in here, but we're looking for pinhole pupils as well. If it's not reacting to light stimuli, that's also a really important sort of sign. It's hard also, again, as I mentioned, to differentiate between what a regular nodding out is versus like a heavy nod. I think what's important here, as mentioned earlier, is that if they're not responding to any type of stimuli, then we can assume that it's an overdose situation. Understandably, because, really access to life-saving medication like Narcan or naloxone is really rather recent in the last decade. A lot of individuals have sought out their own ways of attempting to reverse an overdose, usually from a good place in their heart. I think it's really important. Very common one though is if somebody's overdosing is to splash them with cold water, maybe throw them in a cold shower or like a cold bath. It would make sense, if somebody is sleeping, that you could toss some cold water on their face. But it's really important to note, especially with this, is that if we're talking about respiratory depression, further cooling down an individual's body can be really dangerous and further that respiratory depression and overall central nervous response. And so being super mindful that okay, you might want to splash them with a little bit of water, but understand that prolonged use of some of this may further the risk for continued overdose. I've seen some people, heard about some people injecting salt water, or even like vinegar or something like that, again, to maybe try to clean out the system. Obviously not recommended necessarily because it might not even just do anything. I think that if you're going to be injecting somebody, you got to be pretty sure that it's going to be doing something. And so unfortunately, with this type of thing, it just really doesn't do anything. It's kind of wasted time. I mentioned earlier, undue painful stimulation. It's not worth it to be breaking somebody's rib cage here with a sternum press. If they're not responding, they're not going to be responding. It can be really tempting to throw somebody around, try to wake them up, shake them awake. But again, that might provide some undue harm in the situation. And another one I see too is just sort of like the balancing out with stimulants. Unfortunately, injecting somebody with cocaine or methamphetamine is, you would think that it could reverse like a respiratory depression or other effects from the opioid overdose. Unfortunately, it just doesn't work like that, and it actually may increase someone's chance of continued overdose or even cardiac arrest, depending on what other types of substances they've put in their body. So what is naloxone? This is the sort of the rest of the topic today. And, it's incredible. While we don't have a medication to necessarily reverse a stimulant overdose, we have a proven medication that has been around for decades that with adequate access can essentially just save lives. You have, in some countries where we have these overdose prevention sites, because they have naloxone on hand, they have seen remarkably no overdose deaths in their existence because they have these medications on hand. And so, it's obviously used in emergency overdose situations. It cannot be understated, though, that the majority of people who are reversing overdoses are fellow people who are using drugs. So I think this goes into this sort of larger conversation we can have maybe during the discussion section, where I think as a society, we really push for emergency providers and law enforcement to have access to these medications, which I think can be in good intentions, but unfortunately, because of stigma and discrimination, a lot of people are not going to be reaching out to emergency or law enforcement providers to help reverse an overdose. So it's so essential that we're really getting this medication in the hands of people who are going to be most risk or in a position to really help the most. But as I mentioned, this is that drug that really blocks or reverses the effect of the opioid overdose. It comes primarily in nasal spray form and injectable, in like an intramuscular injection. We've seen some conversations about having like a sublingual spray that somebody could spray under their tongue. I think that's sort of still in flux with FDA currently as well. But we know broad and saturated distribution of naloxone is going to be one of the most correlated factors in reducing overall opioid-related deaths around the country. So Narcan, Nebraska, naloxone, Nebraska. So back in May 2015, there was a legislative bill, 390, that was signed into law, allowing for the dispensation of naloxone without a prescription. This is huge. This was followed up in subsequent years by the Department of Health and Human Services here in Nebraska. But the most updated document right now is the DHHS standing order. So for example, technically, each of us as an individual should be able to go into a pharmacy and purchase Narcan. It's usually about $150 without insurance currently. And so if you have that money, you can go in. If they refuse to sell without a prescription, which is allowable currently, you can use the DHHS standing order to sort of replace that prescription order. And so this is pretty huge. Nebraska's really, I think, meeting the standard across the country around this. And then legislature followed up with a revised statute that provides protection for pharmacists dispensing naloxone. And this is a really important point too, especially for pharmacists who are apprehensive about the dispensation of naloxone, especially for reasons that are not grounded in evidence necessarily, but that this might encourage overdose risk potentially, or encourage people to overuse opioids in some way. This is that protection though for them. If there are concerns about liability, this can be a really good way to address that. I will say, and I'm not going to call any specific pharmacies out, but it's been really interesting to sort of see, what pharmacies are pushing back on this. Sometimes it's a corporate policy, sometimes it's just like local education about these laws. And so a lot of pharmacists around the state, I think it could be really helpful to have this conversation more to make sure that they understand our rights in accessing this medication. So the three primary methods, I call the one on the left the Cadillac version of naloxone, which is, I've seen estimates of this. You essentially can purchase this without insurance for around $3,000 for a 2-kit. As you can imagine, most people probably won't have access to this. And so it's really interesting to sort of see the pricing of this type of thing. Oftentimes it's pretty popular for first responders or law enforcement officers as well, since essentially what it does is it will talk to you through the whole entire process. It's great because it can be injected through pants. And so it's really meant to be used by any individual who might be in the presence of an opioid overdose to be able to support an individual. I've heard a lot of stories about like younger teenagers being able to help their parents using these types of methods and things like that too. So promising, but vastly inaccessible. The one thing that we see the most of is probably the nasal spray, and this is what we actually call Narcan. And so naloxone is the sort of generic name. Narcan is the trademark name for the naloxone overdose spray. And so it's going to be one dose per device. Thankfully, unlike the auto injector, you don't have to do like a priming for it. What I didn't mention is that there's a maximal effect in 30 minutes. So it will reach its maximum effect over a 30-minute period and then decrease pretty quickly into the next 45 minutes, hour. So again, it's super important to be ready to re-administer if necessary. And then what we see probably is like the cheapest form is the naloxone intramuscular kits. This requires usually use like a 22 gauge needle, 21 gauge needle that you can actually draw up the naloxone directly from the vial. It's one dose per vial. And we see this a lot more in like a lot of community-based organizations that have relationships with pharmaceutical companies that can get super discounted products and things like that too. So we see most of the nasal spray, especially in pharmacy spaces, but we see the naloxone intramuscular kits more in the community-based settings as well. So super briefly, because I love to go over time, I wanted to at least, and all these slides will be available too. And I think if you have any questions about some of the documents, there's some really, really good flyers that you can just post up in some of your spaces, just have on hand to be ready for this type of thing. But what the National Harm Reduction Coalition has put out is this eye care procedure, which you're identifying the overdose, really looking at those symptoms, calling 911 like you would do in any type of emergency response, administering the naloxone, providing rescue breathing and CPR, and then ensuring safety while the EMS until the EMS arrive. So identification, simply, right? Like it seems kind of crazy to have to like practice this out, but I mean, what you really want to do is again have that sort of verbal stimulus with an individual first. And so you're not going to be running up to somebody who's sleeping on the street or wherever in your house and just assume that they're overdosing. You're going to try to engage them verbally. You're going to do maybe the sternal rub, you're trying to shake awake a little bit. But again, if there's slow or absent breathing, the individual might be gasping for breath or having this snoring or gurgling sound. If you're able to see their pupils and they are pinpoints, again, what we talked about with some of these risks, the blue or gray, purplish lips and nails, it might be time to administer naloxone, especially if they're not responding. Really important to explain why you're offering naloxone and using those clear and simple words. Most states, and I'm pretty sure in Nebraska, we have that like a Good Samaritan protection where if you are trying to administer this naloxone in good faith, you won't be charged. And I think it's really important to note too, there are very, very, very few side effects with naloxone. I could shoot some up into my nose right now and it would be very unlikely that I would have any type of symptoms from that. So calling 911, this is also like, I would say for our purposes, super essential. It's important to recognize that while we do have some Good Samaritan protections in the state, like you may be putting an individual at risk because of just the current way that we handle overdose and drug possession in the state. And so I always say that as a caveat. I think it's important to call 911, right? But just understanding that may have some sort of impact with the individual you're with. And so just recognizing that. But it is important too, because if you only have like 1 or 2 doses of naloxone, this may impact, if you don't call 911, this individual may fall back into an overdose situation after the naloxone wears off. And so first responders are going to have access to these medications, and so they will be able to help for the long-term support somebody out of this. If you're with other people though, have them call 911 for you, and you can continue to administer support to the individual who might be overdosing. The actual administering naloxone. So, again, you don't have to prime a spray device, no like pumping or anything beforehand. And so you're trying to cover one nostril, and then you will it's a one push up, and it usually has like a pretty quick effect, right? So you're only waiting for, I would go on the lower end, like 2 minutes max, to see if there is some sort of response, especially because we have so much fentanyl saturating our drug markets right now. I've heard stories of people needing 5 or 6 doses of Narcan or naloxone to come out of that overdose sort of situation. And so, super important, and also try to sort of switch nostrils as well if that's not working for the individual. This will be super important just for, I love this graphic though, because it's like super important just to sort of, again, remember the steps of rescue airway breathing, ensuring that the airway is clear. I'm sure if you've taken CPR classes, you can do like a really quick sweep of the oral cavity to make sure there's not any vomit or things like that might be clogging up as well. Placing one hand on the chin, tilting the head back to really open that airway as much as possible. Remembering to pinch the nose closed, and then giving 2 slow rescue breaths in the mouth. Trying to again see if there are chest rises with each breath. I've seen CPR change a lot over the last decade or 2, just as far as like if you need to do chest compressions. For this though, specifically because it's a respiratory failure, the rescue airway breathing is pretty essential if you're able to do that and administer that support. And then finally is on this eye care lineup is ensuring safety, right? So obviously, ideally, you're not getting the person overdosing any more opioids. There's no purpose for that currently. After you have administered rescue breathing, if the individual is sort of slowly waking up, you can place them into the rescue position as seen on the right here. And really, remembering that if naloxone or Narcan is replacing all of these opioid receptors for a short period of time, the individual might fall into pretty intense withdrawal symptoms. And so maybe very nauseous, may lose function of bowels and things like that. And so trying to put them in a safer position, especially if there might be any vomiting, is essential. Again, you're waiting for those 2 to 3 minutes max to see if there is a response, and just trying to clear and create a safe space for that individual as they're hopefully coming back to. So yeah, as I sort of said with this recovery piece, it's really important that if emergency responders are not present or en route, that you are hanging around with this individual for a while after you've administered the naloxone or Narcan. Even if somebody wakes up, again, because the naloxone has such a short half-life, if it goes away, an individual might go back into overdose. And so you might have to re-administer or, recontact 911 if they haven't been contacted yet. But also just remember, I hear horror stories about, I think I hear a lot of fears amongst like emergency responders about folks being really violent. That is like extremely, extremely uncommon. I think it's like a 2 to 3% of all cases, people are going to respond violently from this. And so not really a reason to be able to administer aid to an individual in the moment. So to sort of close this out a little bit, naloxone in Lincoln, back in December, DHHS started a pilot program that will run up until this upcoming December to get free naloxone. And so you can go to the Kohl's or Waggy drugstore over on 27th Street or Hy-Vee on 5010 O Street and request naloxone. You don't have to present any like symptoms or risk factors. And you should be able to get your free 2 doses of Narcan nasal spray. And I encourage everyone to do this, even if you don't know an individual who is in a position that may overdose. You never know who you might come across or who in your life might be using opioids who might need this medication. And so, we're changing, I think, our sort of framing here in the state of Nebraska to really support that access. And so I think it's really, really important that we take advantage of it while it's here. I will say to that note, actually, real quick. So the expiration date on a lot of naloxone or Narcan can be 1 to 2 years, but there have been numerous studies that have looked into the efficacy of naloxone after sort of extreme climate conditions, whether it's like freezing or boiling the naloxone or, doing simulated aging of like 30 to 40 years. And it's actually proven to be still fairly effective. And so even if your kits, expire, that they still may very well be effective. And so obviously if you're working for an agency or a study, still following guidelines on having medication with current expiration dates is important. Another actually resource I wanted to highlight though is this organization called Next Distro, and their website is nextdistro.org. And they are a mail service that operates nationally you can order supplies through Next Distro and actually have them delivered. And this includes even like safer injection supplies and things like that. Highly recommend it, especially I think that probably the majority of the naloxone that they're going to be distributing is going to be the intramuscular injectable. So just sort of keep that in mind. Obviously, it's going to be quite different from administering the nasal spray, but an incredible resource, especially if you're working with participants, clients, folks who may be at risk. This is like a really great resource if they feel comfortable ordering to an address to get needed supplies. I went quite a bit longer than I expected, but I'd like to at least answer any questions if you have any, and then just go open to some general discussion if you have any questions about that. But any, I guess, initial thoughts or questions on some of this content?
Good info, appreciate it.
Hey, thank you.
I had a quick question just about kind of like timing. So do you know typically like after somebody injects and like if they are on the path to overdose, what's the kind of time from injection to when they enter that overdose state?
Super good question. I mean, it's very hard, I think, to have like a general estimate just because there's just so many different things that are cut into drugs these days.